1. Disclaimer. I do not own the rights to the images or information provided. This was strictly made for the purpose of studying for boards. The upper motor neuron, UMN, is the motor system that is confined to the central nervous system, CNS, and is responsible for the initiation of voluntary movement, the maintenance of muscle tone for support of the body against gravity, and the regulation of posture to provide a stable foundation upon which voluntary activity is initiated. Traditionally, it has been divided into pyramidal and extrapyramidal components. This separation is more significant in primates, in which the pyramidal system is more highly developed and has more important functions and have been observed in domestic animals. The pyramidal system consists of neurons whose cell bodies are located predominantly in the motor area of the cerebral cortex and whose axons descend through the white matter of the cerebral hemisphere and brainstem, including the pyramid on the ventral surface of the medulla. The pyramid is so named for its pointed shape in primates. It contains only the projection pathway of the neurons of the pyramidal system. Their telodendron is in the gray matter of the caudal brainstem and the spinal cord. In the spinal cord, this is an uninterrupted monosynaptic corticospinal pathway from the cerebrum to the spinal cord by way of the pyramids of the medulla. In contrast, the extrapyramidal system consists of neurons that originate in the cerebral cortex, including the motor area, and descend into the brainstem directly or by way of basal, subcortical, nuclei. Synapse occurs with additional neurons in the basal nuclei and brainstem nuclei. Axons of these neurons course quadrantally from specific brainstem nuclei into the spinal cord without traversing the pyramids of the medulla. The telodendron of the brainstem neuron is in the gray matter of the spinal cord. This is a multineuronal, multisynaptic corticospinal pathway. The pyramidal and extrapyramidal systems overlap anatomically and function together. The extrapyramidal system is of much greater importance in the domestic animal. The two systems will be considered together as a UMN in all clinical discussions. Pyramidal system. The development of the pyramidal system is directly related to the capacity of an animal to perform skilled movements. In primates, its termination in the spinal cord is most dense in the areas of the lateral portion of the ventral gray horn in which the cell bodies of the general somatic efferent, GSE, lower motor neuron, LMN, two muscles of the digits are located. Here, it may synapse directly on the dendritic zone of the alpha motor neuron, GSE. This anatomic arrangement occurs in primates and in the raccoon, two unrelated species that possess considerable manipulative ability in their thoracic limb digits. The pyramidal system is poorly developed in domestic animals, especially in the horse, ox, and sheep. In the horse, this system makes a sizable contribution to the facial nuclei, the location of the GSE, LMNs that innervate muscles for lip movement, which suggests that these muscles of prehension perform the most highly skilled activity in this species. This system also dominates in the spinal cord dorsal gray horn, where it influences the activity of cranial projecting sensory systems. The cell body of the pyramidal system neuron is located in the cerebral cortex. The majority are located in the motor area in the frontal lobe or the adjacent parietal lobe, figure 8-1. In primates, this involves primarily the procruciate gyrus. In carnivores, it overlaps on the sensory area, where it is limited to the postcruciate and rostral supercilium gyri. In ungulates, the motor area is located medially along the frontal lobe in the region of the precruciate gyrus. Electrophysiologic stimulation studies have shown that these motor areas may be subdivided into the regions of the body that are innervated by LMNs receiving impulses from the pyramidal system neurons that originate in the specific parts of the motor cortex. This is referred to as somatotopic organization, in which the various portions of the body are represented topographically on specific regions of the cerebral gyri. The homunculus drawn on the surface of the human cerebral hemisphere depicts this phenomenon. Regions involved with more highly skilled functions have a larger representation in this motor area. Muscles with small motor units also have a larger area of representation. The primary motor area of one cerebral hemisphere serves the musculature on the contralateral side of the body. In the carnivore, the postcruciate gyrus is related to the innervation of the appendicular musculature. The supercilium gyrus is related to the motor function of the cervical muscles and the muscles of specific areas of the head. In addition to these motor areas, some components of the pyramidal system have cell bodies in the premotor area, the sympathetic area, and related areas. Many of these pyramidal system cell bodies are large and are referred to as giant pyramidal cells or Betz cells. They are located in lamina 5 of the cerebral cortex of the gyri that comprise the motor area of the cerebral cortex. The axons of these cell bodies descend through the white matter of the brain in the following order: the corona radiata of the gyrus in the motor area, the cerebral centrum semiovale, the internal capsule of the telencephalon and diencephalon, the central portion of the crus cerebri of the mesencephalon, the longitudinal fibers of the pons, and the pyramid of the medulla. At the caudal end of the pyramid, 75% or more of these axons cross in the pyramidal decussation and pass through the gray matter to the dorsal portion of the lateral funiculus. See plate 14 in chapter 2. The decussation is not visible on the ventral surface of the medulla because it occurs as the crossing fibers course dorsally into the parenchyma of the junction between the medulla and the first cervical spinal cord segment. These crossed pyramidal system axons form the lateral corticospinal tract medial to the cranial projecting spinocerebellar tracts in the dorsolateral funiculus. In the dog, as the lateral corticospinal tract courses caudally, about 50% of these axons terminate in the cervical spinal cord gray matter, 20% in the thoracic spinal cord gray matter, and 30% in the lumbosacral spinal cord gray matter. Most synapse on interneurons in the ventral gray horn that influence the GSE, LMNs located here. Neurons of the pyramidal system that have their cell bodies in the sympathetic cerebral cortex synapse on neurons in the dorsal gray horn to influence the activity of projection sensory systems. The remaining 25% or less of the pyramidal axons in the medulla continue caudally without crossing and enter the ventral funiculus adjacent to the ventral median fissure, where they comprise the ventral corticospinal tract. The axons in this tract course caudally to about the level of the mid-thoracic spinal cord segments. Prior to terminating in the gray matter along this course, these axons cross to the opposite side. Their synapses are similar to those described for the axons of the lateral corticospinal tract. In cats, this pyramidal system serves the entire spinal cord gray matter. In ungulates, the entire pyramidal system is confined primarily to the cervical spinal cord segments. In addition to the corticospinal axons of the pyramidal system, other axons of the pyramidal system terminate in the brainstem to synapse in nuclei of cranial nerves with GSE, LMNs. These are called corticonuclear axons. Corticoarticular neurons synapse in a component of the reticular formation. The axons of the pyramidal system are organized regionally in the various portions of the central white matter where they are located. In the crus cerebri, the pyramidal system comprises the projection axons in the center of this crus. The axons to the lumbosacral intumescence, pelvic limb, are lateral. Those projecting to the cervical intumescence, the thoracic limb, are in the middle, and those projecting to the brainstem nuclei, the head muscles, are medial. In the cat, the pyramid in the middle has been mapped according to the muscle groups affected by its axons. Disturbances in the pyramidal system demonstrate the differences in the roles this system plays in primates compared with its roles in domestic animals. Lesions in the cerebral components of this system in humans cause paralysis of the contralateral voluntary muscle activity that is especially evident in the hands and feet. complicated and involves the muscles used in highly skilled functions. In dogs and cats that are examined a few days after experimental surgical removal of the frontoparietal lobes, motor area, no defect is seen in the gait when the animal walks on a level surface. However, these animals do have a deficiency in their responses to testing of postural reactions in the contralateral limbs. This is most readily appreciated when the hopping responses are tested. Similarly, experimental surgical sectioning of the axons of the canine pyramidal system in the crus cerebri does not affect gait. A variety of naturally occurring cerebral lesions in the same area in all species of domestic animals present with a similar clinical syndrome of gait preservation and deficiency of contralateral postural reactions. Because these lesions usually also involve the conscious projections of the general proprioceptive and visual systems, such lesions are discussed in chapters 9 and 14, with examples in the latter chapter. Histology of the cerebral cortex. The cerebral cortex is made up of an elaborate organization of neural structures with innumerable connections that form the basis for the numerous functions allotted to it. They include consciousness, intellect, emotion, behavior, perception, and control of somatic and visceral motor functions. They are performed by the reciprocal relationship between the cerebral cortex and the rest of the central and peripheral nervous systems. The cerebral cortex is the layer of gray matter that covers the white matter of each cerebral gyrus. This cortex varies from 1.5 to 4 mm in thickness and is situated between the pia mater on the surface and the underlying white matter, which it covers. This white matter is the corona radiata of the neocortex. The cortex contains neuronal cell bodies of many different sizes and shapes, axons, telodendria, dendritic zone processes, neuroglial cells, and an abundance of blood vessels, especially capillaries. Figure 8-2 and 8-3. The neurons in the cortex constitute a system of chains of interrelated neurons. The cortex is a laminated structure based on the organization of the processes. Myeloarchitectonics are based on the arrangement of the cell bodies. Cytorchitectonics. When viewed according to the organization of the cell bodies, as many as 6 layers can be recognized. See figure 8-2. The extent to which each of the 6 laminae is developed varies throughout the cerebral hemisphere. In general, the neopallium has 6 layers and the archipallium, hippocampus, and poliopallium, olfactory cortex, have fewer layers. Some functional significance has been attached to the variation in the neocortical laminations in the different regions of the cerebrum. Maps have been prepared that show the laminar variations that occur throughout the cerebrum. Some include more than 100 different areas based on cytorchitectonic studies. The cortical lamination of the archipallium and the poliopallium is different from the lamination of the neocortex, and it is different in each one. Specific characteristics of each permit their identification. In general, the neocortical neuronal cell bodies are of 2 types. The stellate or granule neuron has a round cell body and short processes that are usually confined to the cortex. The pyramidal neuron has a pyramid-shaped cell body that varies in size and has long processes. The axon of the pyramidal neuron projects from the cortex into the underlying white matter of the corona radiata as an association axon coursing to another cortical area in the same cerebral hemisphere, or as a commissural axon that crosses to a cortical area in the opposite cerebral hemisphere, or as a projection axon that projects to nuclear areas in the brainstem or spinal cord. The corticospinal neuron is an example of the last type. Each area of cerebral cortex receives axons from other cortical areas in the same cerebral hemisphere, association, from the opposite cerebral hemisphere, commissural, and from the brainstem, especially the thalamus, projection. The study of the arrangement of these processes within the cortex, including the processes of the granule neurons, is referred to as myeloarchitectonics. In the neocortex, the 6 layers, from superficial to deep, consist of the molecular layer, external granule layer, pyramidal layer, internal granule layer, ganglion layer, and multiformic layer. See figure 8-2. The processes of the molecular and external and internal granule layers are confined to the cortex. Axons from the pyramidal, ganglionic, and multiformic layers compose the cortical efferents that form the association, commissural, and projection pathways. Extrapyramidal system. The extrapyramidal system embraces diverse, scattered groups of interconnected and functionally related structures that form a series of neurons in a multisynaptic pathway from the cerebrum to the LMN of the brainstem and spinal cord. Figure 8-4. These pathways do not traverse the pyramids of the medulla but function with the pyramidal system by providing tonic mechanisms for the support of the body against gravity and by recruiting spinal reflexes for the initiation of voluntary movement. These functions are performed ultimately by the influence of this UMN system on the alpha and gamma motor neurons, LMN, in motor nuclei in the brainstem and in the ventral gray columns of the spinal cord. The cell bodies of neurons in the extrapyramidal system are located in nuclei in all divisions of the brain. The more important of them are described for each of the brain divisions, along with the courses of their axons. Only the extrapyramidal nuclei in the mesencephalon and rhombencephalon have axons that descend the spinal cord to influence the activity of the lower motor neurons. Telencephalon neuronal cell bodies in the telencephalon, cerebrum, are located either on the surface and laminae of the cerebral cortex or deep to the surface in subcortical nuclei known as basal nuclei. Some authors refer to these as basal ganglia, but this is a misnomer because ganglia, by definition, are collections of neuronal cell bodies in the peripheral nervous system. Cerebral cortex extrapyramidal neurons are located in the cerebral cortex throughout the cerebrum, but most are in the cortex of the motor area and adjacent gyri of the frontal and parietal lobes. Their axons project to basal nuclei and other extrapyramidal nuclei in the brainstem. Basal nuclei. The basal nuclei are subcortical collections of neuronal cell bodies in the cerebrum. They include the septal nuclei and amygdala, which function in the limbic system. The caudate nucleus, nucleus accumbens, putamen, pallidum, and colostrum are extrapyramidal basal nuclei. Figures 8-5 through 8-7. See also figure 8-4, which are generally considered to be involved with motor activity. The putamen and pallidum are referred to as the lentiform nucleus because of their collective overall shape on transverse or dorsal plane sections. The term corpus striatum includes the caudate nucleus, nucleus accumbens, pallidum, putamen, and colostrum along with the portions of the internal and external capsules of white matter that are related to these basal nuclei. The caudate nucleus is located primarily in the floor of the rostral part of the lateral ventricle, medial to the internal capsule. See plates 2-4 in chapter 2. The large head and most of the body are rostral to the diencephalon. The body narrows as it extends caudally, dorsolateral to the diencephalon and medial to the internal capsule. See plates 5 and 6 in chapter 2. It is continued by a small tail that curves ventrally into the temporal lobe of the cerebrum. The tail is C-shaped as it curves around the internal capsule. Dorsally, it is medial to the internal capsule, and ventrally, it is lateral to it. The ventral portion ends just caudal to the amygdala. The caudate nucleus receives axons from extrapyramidal neurons in the cerebral cortex. neocortex, and many of its axons project to the adjacent pallidum. Nigrostriatal projections are axons of cell bodies in the mesencephalic substantia nigra that project primarily to the caudate nucleus. The nucleus accumbens is a ventral extension of the head of the caudate nucleus. It surrounds the ventral portion of the rostral horn of the internal capsule. The lentiform nucleus comprises the pallidum, globus pallidus, medially and the putamen laterally. The two nuclei are separated by an irregular layer of white matter. The nucleus is bounded medially by the internal capsule and laterally by the thin external capsule. See plates 2-5 in chapter 2. The nucleus begins rostrally in the frontal lobe, where it is separated from the head and body of the caudate nucleus by the internal capsule. It extends caudally through the parietal lobe and into the temporal lobe to a level caudal to the amygdala in the piriform lobe, where the ventral portions of the lateral ventricle and hippocampus are located. The pallidum is medial to the putamen and is interspersed in the lateral ventral portion of the rostral horn of the internal capsule, which gives it a reticulated pattern. The endopeduncular nucleus is a mediaventral extension of the pallidum that is most obvious where it is positioned between the internal capsule and the optic tract. See plates 4 and 5 in chapter 2. The putamen is the largest portion of the lentiform nucleus and is lateral to the pallidum. It blends with the internal capsule and caudate nucleus rostral to the pallidum and is separated laterally from the colostrum by the external capsule. The colostrum forms a long thin plate lateral to the external capsule. See plates 2-6 in chapter 2. It extends from the level of the head of the caudate nucleus rostrally to the level of the ventral extent of the lateral ventricle in the temporal lobe caudally. A very thin layer of white matter, the extreme capsule, separates part of this plate from the neocortex of the lateral aspect of the cerebral hemisphere. The ventral portion of the colostrum blends with the adjacent neocortex. A feedback circuit is provided by a multisynaptic pathway from the neocortical extrapyramidal neurons to the caudate nucleus, to the pallidum, to the ventral rostral nucleus of the thalamus, to the neocortex. Figure 8-8. At the time of cortical initiation of voluntary movement, such a circuit provides a modifying control mechanism. Certain specific thalamic nuclei serve to project information from the brainstem to the cerebrum. The ventral rostral thalamic nucleus is an example of such a projection nucleus for the extrapyramidal system. Diencephalon. The extrapyramidal nuclei are located in the ventrolateral portion of the diencephalon, which is the subthalamus. Figure 8-9. This includes the endopeduncular nucleus, the zona incerta, and the subthalamic nucleus. The endopeduncular nucleus is in the subthalamus but was described in the cerebral hemisphere with the pallidum. In primates, this is the medial portion of the pallidum. In domestic animals, the endopeduncular nucleus extends medially from the pallidum between the optic tract and the internal capsule. It extends caudally, lateral to the hypothalamus. See figure 2-13 in plates 4 and 5 in chapter 2. The zona incerta is a narrow nucleus located dorsomedial to the ventral thalamic portion of the internal capsule and lateral to the external medullary lamina of the thalamus. It extends through most of the subthalamus. See plate 6 in chapter 2. The subthalamic nucleus is in the caudal diencephalon, caudal to the endopeduncular nucleus on the dorsomedial surface of the crus cerebri. See plate 6 in chapter 2. All three of these nuclei are connected to the extrapyramidal nuclei in the telencephalon and caudal brainstem by afferent and efferent axons, but no axons project directly to the spinal cord. Mesencephalon. The two well-defined extrapyramidal nuclear areas in the midbrain are 1. The substantia nigra and 2. The red nucleus. Figure 8-10. The substantia nigra is so named because its cell bodies contain a melanin pigment that increases with age and is macroscopic in some species. This nucleus may be found throughout the length of the mesencephalon, dorsal to the crus cerebri and ventral to the tegmentum. See plates 7 and 8 in chapter 2. It is bounded rostrally by the subthalamic nucleus. Many of the substantia nigra neurons project rostrally to the caudate nucleus. Dopamine, which is synthesized by the substantia nigra neurons, is secreted as the neurotransmitter at this level. This is referred to as the nigrostriatal system. The red nucleus is a well-defined round nucleus in the tegmentum at the level of the rostral colliculi and ventrolateral to the motor nucleus of the oculomotor nerve. See transverse section in MR image plates 7 and 8 in chapter 2. It receives a group of afferent axons from the ipsilateral motor area of the neocortex by way of the internal capsule and crus cerebri. Axons of the cell bodies in the red nucleus immediately decussate at the level of this nucleus in the tegmentum and course quadrily as the ribrospinal tract. This tract courses from the ventrolateral mesencephalon through the pons and medulla into the lateral funiculus of the spinal cord. Here, the tract is closely associated with the lateral corticospinal tract deep to the superficially positioned, cranially projecting spinocerebellar tracts in the dorsal portion of the lateral funiculus. The ribrospinal tract extends through the entire spinal cord. Its axons terminate on interneurons in the ventral gray column of the spinal cord. These interneurons, in turn, influence the activity of the GSC alpha and gamma LMNs. This corticoribrospinal tract is organized somatotopically. The neurons in the thoracic limb area of the motor cortex project to the dorsal part of the red nucleus. The neurons in this dorsal part of the red nucleus project to the ventral gray column of the spinal cord segments that innervate the contralateral thoracic limb muscles. Corticocerebral neurons from the pelvic limb region of the motor cortex synapse in the ventral part of the red nucleus, whose neurons project to the ventral gray column of the spinal cord segments that innervate the contralateral pelvic limb muscles. The red nucleus neurons are predominantly facilitatory to motor neurons of flexor muscles and therefore function in the initiation of protraction of the limbs and gait generation. The ribrospinal neurons affect gait generation via the components of the cervical and lumbosacral intumescences that comprise the central pattern generators. Ribronuclear axons course with the ribrospinal axons and at various levels leave the ribrospinal tract as it courses through the caudal brainstem. The ribronuclear axons synapse in the cranial nerve nuclei that contain GSE, LMNs. The red nucleus also participates in a feedback circuit between the neocortex and the cerebellum. See figure 13-20. A significant number of neurons in the neocortex projects their axons to the ipsilateral pontine nucleus. The axons of these pontine cell bodies cross in the transverse fibers of the pons to enter the cerebellum via the contralateral middle cerebellar peduncle. Synapses occur in the cerebellar cortex. They are described with the cerebellum in chapter 13. Ultimately, the neural impulses from the cerebellar cortex activate a cerebellar nucleus, whose axons emerge from the cerebellum in the rostral cerebellar peduncle. These axons cross in the tegmentum of the midbrain, and some of them terminate on neuronal cell bodies in the contralateral red nucleus. The axons of these neurons course to the thalamus and synapse in the ventral rostral nucleus, whose axons project to the neocortex. This is a cerebropontocerebellar cerebellar cortical circuit that begins and ends in the same area of neocortex. Connections from the red nucleus to telencephalic basal nuclei also exist. Reticular formation Before describing the components of the extrapyramidal system in the rhombencephalon, it is necessary to define the reticular formation. The reticular formation is a collection of neuronal cell bodies of various sizes and a plethora of processes that form an ill-defined meshwork in the central core of the brainstem. It extends from the medulla to the caudal diencephalon. Many functions are attributed to the reticular formation. One major function is the role it plays in activating the cerebral cortex to establish the awake state and the level of consciousness. This is referred to as the ascending reticular activating system and is described with the diencephalon in Chapter 19. The reticular formation is also involved in the various neural connections that induce sleep. Several groups of reticular formation neurons make up the brainstem centers that are involved in the caudally projecting UMN control of respiration, cardiovascular function, voluntary excretions, swallowing, vomiting, and muscle tone and voluntary movement. The extrapyramidal system is involved in this caudally projecting pathway that influences the GSE and GVE elements involved in voluntary and involuntary motor activity. Rhombencephalon, a pontine and a medullary nucleus are components of the reticular formation that have a major role in the UMN extrapyramidal control of weight support in the generation of gait. Studies in the cat have defined an area of the reticular formation in the pons that exerts a facilitatory influence on spinal cord GSE neurons that innervate extensor muscles by way of a reticulospinal tract. See Plate 10 in Chapter 2. This pontine reticulospinal tract courses mostly in the ipsilateral ventral funiculus. Similarly, an area of the medullary reticular formation has an inhibitory influence on spinal cord GSE neurons that innervate extensor muscles by way of a medullary reticulospinal tract that courses primarily in the central portion of the ipsilateral lateral funiculus. These pontine and medullary reticular formation nuclei are activated predominantly by corticorticular pathways from the contralateral cerebral hemisphere. These corticorticular axons cross the midline of the brainstem at the level of the reticular formation nuclei. Most of the axons of the cell bodies in these pontine and medullary reticular formation nuclei make up the pontine reticulospinal tract and the medullary reticulospinal tract that course caudally in the ipsilateral ventral and lateral funiculi, respectively. Thus, this pathway permits one cerebral hemisphere to control predominantly the motor activity on the opposite side of the body. This contralateral influence is observed in both the motor and the sensory systems. The olivary nucleus is considered an extrapyramidal nucleus in the medulla. It is located ventrally in the medulla from a level caudal to the facial nucleus to a level caudal to the orbix and rostral to the pyramidal decussation. It is dorsolateral to the pyramis and medial lemniscus and medial to the hypoglossal axons that are coursing ventrolaterally. See Plates 14 and 15 in Chapter 2. It is composed of 3 nuclear groups that at some levels have the appearance of fingers directed ventrolaterally. This extrapyramidal nucleus receives afferent axons from many of the extrapyramidal nuclei in the telencephalon, diencephalon, and mesencephalon. Its efferent axons project primarily to the contralateral portion of the cerebellum. These axons leave the olivary nucleus and immediately cross the midline dorsal to the pyramids, intermingle with the axons in the medial lemniscus, and continue rostrally in a dorsolateral position to enter the caudal cerebellar peduncle, where they are distributed to the cerebellum. This is a major source of extrapyramidal system projection to the cerebellum. An extrapyramidal system feedback circuit also exists between the cerebral hemisphere and the cerebellum via this olivary nucleus. Figure 8-11. See also Figure 13-20. In this description of the extrapyramidal portion of the UMN, the final motor pathways by which this system exerts influence over the GSE, LMN are the ribrospinal and the pontine and medullary reticulospinal tracts. Many other brainstem tracts also course to the spinal cord and influence muscle tone and activity by their connections in the spinal cord ventral gray columns. These include the vestibulospinal tracts, the medial longitudinal fasciculus, and the tectospinal tract. Some texts include these tracts with a description of the extrapyramidal system. However, in this text, they will be considered with the various systems that have their own anatomic components and functional attributes separate from that interrelated with the extrapyramidal system. Most of these tracts influence the GSE, LMN through interneuronal connections in the spinal cord gray matter, where these extrapyramidal system tracts terminate. In addition, some long spinal interneurons course in both directions in the spinal cord and participate with the UMN in the control of the LMN. A comparison of the development of the UMN tracts in the human, the cat, and the horse craniocervical spinal cords reveals the decrease in importance of the pyramidal system, corticospinal tract, and the increase in the contribution of the extrapyramidal system, ribrospinal tract, in the domestic animal. Figure 8-12. Upper motor neuron function. The functions of the UMN are summarized as follows. 1. The initiation of voluntary activity of the motor system. 2. The maintenance of muscle tone to support the body's weight against gravity and to establish the posture on which the voluntary activity can be performed. And 3. The control of the muscular activity associated with the visceral functions, respiratory, cardiovascular, and excretory. Neuromuscular spindles. Neuromuscular spindles have a significant role in the function of the UMN. This system carries out its function by influencing the activity of the alpha and gamma motor neurons in the ventral gray columns of the spinal cord. The activity of the neuromuscular spindles in modulating muscle tone involves their control over the stretch reflexes in which the neuromuscular spindles play a major role as a sensory organ. These spindle organs are located in the belly of skeletal muscle. Figure 8-13. They are spindle-shaped structures composed of intrafusal fibers that are very small, modified striated muscle cells. These cells are positioned in parallel with the large extrafusal muscle cells in which the spindles are located. A connective tissue capsule encloses the small group of intrafusal fibers and is attached to the endomysium of the adjacent extrafusal fibers. Within the spindle, 2 types of intrafusal fibers exist. The nuclear bag fiber is interrupted near its middle by a non-striated dilation containing most of the cell's nuclei. The nuclear chain fiber has no central dilation, although most of its nuclei are accumulated near the middle of the fiber. These features create for the spindle a central distended nuclear region augmented by a lymph space that envelopes the middle portion of the intrafusal fibers. The poles of the spindle are tapered and contain the contractural striated portion of the intrafusal fibers. The intrafusal fibers are innervated in the polar regions by small myelinated neurons, whose cell bodies are in the ventral gray horn of the spinal cord intermingled with the larger GSE neurons. These small neurons are called gamma efferent neurons. The larger GSE neurons are referred to as alpha efferent neurons. The gamma efferent neurons are further divided into plate and trail gamma efferent neurons. The 2 types of gamma efferent neurons are named according to the forms of their terminations on the intrafusal fiber. The gamma plate neurons terminate on the striated muscle fiber component of the nuclear bag. Intrafusal muscle fibers within the neuromuscular spindle. The nuclear bag region is surrounded by the annulospiral dendritic processes of a sensory neuron whose axon is large, and this neuron is classified as 1A. Their cell bodies are in a spinal ganglion, and the axons enter the spinal cord via the dorsal root, where they traverse the dorsal gray horn and enter the ventral gray horn. There, they synapse directly on a GSE alpha motor neuron of an extensor muscle, causing its contraction. This is described as a tonic gamma loop mechanism, and it is responsible for maintaining normal muscle tone. Impulses are stimulated in the annulospiral dendritic zone of the one afferent by any action that stretches the nuclear bag region of the spindle. This occurs passively through the stretch of the extensor muscle by gravity or actively through a brief tap on the tendon of the muscle by a blunt instrument, as in the patellar reflex. Active stretching of the nuclear bag results from the contraction of the intrafusal fibers mediated by the gamma afferent neurons. The gamma trail neurons terminate on the polar areas of the nuclear chain striated intrafusal fibers in the neuromuscular spindle. Group I sensory neurons innervate the polar chain fibers on both ends of the neuromuscular spindle, and their dendritic zones respond to the active contraction of the nuclear chain muscle cells. These group I sensory neurons terminate in the spinal cord ventral gray horn on interneurons that are inhibitory of the GSE alpha neurons that innervate flexor muscles. This is referred to as the phasic gamma loop, or flexor reflex gamma loop, and it functions with the UMN to initiate flexor reflexes in the generous scion of the gait. Posture is maintained against the steady force of gravity by this neuromuscular spindle activity. The force of gravity stretches extensor muscles in the nuclear bag region of their spindles. The one afferent is stimulated. In turn, it stimulates the GSE alpha afferent neuron to cause contraction of the extrafusal fibers of that extensor muscle. Collaterals of the same one afferent stimulate interneurons in the ventral gray horn that are inhibitory of the GSE neurons that innervate those muscles that are antagonists of the action of the extensor muscle. The activity of this stretch, or myotatic reflex, maintains a constant low-level state of contraction, which provides for muscle tone. Other collaterals of the one afferents are involved in cranial projection of general proprioceptive pathways to the cerebellum and sympathetic cortex, which provides these higher centers with information about the state of muscle contraction to be used in the proper coordination of motor activity. The UMN extrapyramidal system influences the activity of these myotatic reflexes by its caudally projecting spinal cord axons that terminate on gamma afferent cell bodies in the ventral gray horn. Golgi tendon organs are the receptors that house the dendritic zones of the 1B sensory neurons that are located in tendons. They have a higher threshold to the stimulus of stretching muscles than the 1O annulospiral afferents. The 1B sensory neurons are stimulated when the tendon is stretched by contraction of the extrafusal fibers in the muscle that are continuous with this tendon. Within the ventral gray horn of the spinal cord, the 1B afferent axons synapse on interneurons that are inhibitory of the GSE alpha motor neurons innervating the contracting muscle, as well as synapsing on interneurons that are facilitatory of the GSE alpha motor neurons innervating the antagonist of this muscle, thus lowering the threshold to stimulus. This inverse myotatic reflex provides for smooth skeletal muscle activity and protects against the overstretching of tendons. Gait generation. The interaction of these UMN pathways, the ventral gray column interneurons, the alpha and gamma afferents, and the neuromuscular spindles are all critical factors in postural support in the generation of gait. This is critical for the student and clinician to understand because knowledge of the various gait disorders is the basis for making the correct anatomic diagnosis in the majority of the neurologic disorders in patients. Locomotion, or gait generation, may be divided into two components. 1. A postural phase, and 2. A protraction, swing, phase. The postural phase requires the facilitation of neurons that innervate anti-gravity extensor muscles. This is the weight-supporting action of muscles. The protraction phase requires the facilitation of neurons that innervate flexor muscles to initiate movement and the facilitation of neurons that innervate extensor muscles to complete the movement. Both of these phases require the UMN recruitment of spinal reflex mechanisms via the activation of what neurophysiologists refer to as the central pattern generators. The central pattern generator is the network of interconnected interneurons in the spinal cord gray matter that modulates motor neuron activity for the generation of gait. These interneurons function between the UMN and the GSE, LMN, and between the spinal nerve afferents and the GSE, LMN. The role of the UMN in this gait generation is mediated through the central pattern generator. The central pattern generators located in the spinal cord and tumescences are the ones most involved with the gait generation. Although a locomotor pattern may occur as the result of spontaneous activity of the central pattern generator, especially for the pelvic limbs, it is not useful for the patient's locomotion. This is called spinal walking and may occur many weeks after a transverse spinal cord lesion that interrupts all of the UMN pathways cranial to the generator. For normal locomotion, the UMN pathways are responsible for stimulating, via the central pattern generators, the appropriate GSE, LMNs that induce the postural and protraction phases of locomotion. The complexity of this neural arrangement is profound. For learning purposes, it is useful to attempt to translate the arrangements into the functional roles of individual brainstem nuclei and spinal cord tracts, but any such description is obviously an oversimplification of a complex system. In the domestic animal, the roles of the motor cortex of the cerebrum and the corticospinal tracts in locomotion are relatively minimal compared with those roles in primates. This observation is based on the finding that experimental removal of this portion of the cerebral hemisphere and natural disorders such as brain tumors and malformations that interfere with its function do not affect gait generation. The extrapyramidal system brainstem nuclei caudal to the diencephalon are considered to be the most important UMN systems necessary for gait generation. Figure 8-14. The postural phase of the gait is dependent on the activation of anti-gravity extensor muscles and the inhibition of the flexor muscles. This is the responsibility of the pontine reticular formation nuclei and pontine reticulospinal tracts. The vestibular nuclei and vestibulospinal tracts also contribute to this function. The initiation of protraction requires the activation of flexor muscles and the inhibition of extensor muscles to elevate the limb from the ground. This is a function of the medullary reticular formation nuclei and their medullary reticulospinal tracts and of the red nuclei in the ribrospinal tracts. As the protraction phase is completed, the activation of these systems shifts back to the activation of extensor muscles and inhibition of flexor muscles. Further support for the role of the UMN system in locomotion is provided by observation of the results of experimental or natural lesions. Experimental lesions that selectively destroy the motor cortex, the lentiform nucleus, or the quadrate nucleus do not affect gait generation. Experimental or natural lesions that destroy the frontoparietal cortex or the adjacent portion of the internal capsule do not interfere with gait generation, but the postural reactions are deficient in the contralateral, opposite side, limbs. However, the components of the UMN system affected here are mixed with components of the conscious portion of the general proprioceptive, GP, system, which are also necessary for postural reactions to be normal. We consider that chronic cerebral lesions do not interfere with gait generation but do result in delayed hopping responses in the contralateral limbs as a result of the loss of function of both the UMN and the conscious GP systems located there. This should not be referred to solely as a hemiparesis because because the GP system is also involved in the lesion. Case examples are described after the discussion of the GP sensory system in Chapter 9. The only exception to this is that with acute, especially traumatic and vascular cerebral lesions, mild contralateral hemiparesis and loss of general proprioception may be observed in the gait for 2 to 3 days following the onset of the lesion. After that, the gait will be normal, but the contralateral postural reactions will be deficient. Consequently, the term hemiparesis should not be applied to these cases where the gait has returned to normal. Hemiparesis is a descriptive term for a visible gait impairment in motor function, progressing caudally in the brainstem. Experimental surgical ablation of one red nucleus does not induce any gait interference. However, most natural lesions that involve the red nucleus in the midbrain on one side also affect the adjacent pontine reticular formation, which interferes with gait generation and causes hemiparesis. When the lesion affects the pontine and medullary reticular formation UMN nuclei or tracts, the hemiparesis is observed in the ipsilateral, same side, limbs. Lesions on one side of the middle or cervical spinal cord cranial to the C5 segment that affect the UMN cause a similar ipsilateral hemiparesis or hemiplegia. This raises the interesting question whether unilateral lesions shift from affecting primarily the contralateral limbs to affecting the ipsilateral limbs. We do not know the exact level but believe that it is close to the caudal midbrain. Unilateral prosencephalic UMN lesions cause no loss of gait generation but cause deficient postural reactions in the contralateral limbs. UMN lesions in the brainstem caudal to the midbrain cause gait deficit, ipsilateral hemiparesis, and postural reaction deficits in those limbs. A severe unilateral caudal medullary UMN lesion may cause ipsilateral hemiplegia. An infarct in one side of the cervical spinal cord cranial to the C5 segment caused by fibrocartilaginous emboli will cause complete UMN paralysis. Spastic hemiplegia of the ipsilateral limbs. Case examples are presented in Chapter 10. Clinical signs of oculomotor neuron disease. Paresis disorders that interfere with the ability of the UMN to initiate gait generation result in paresis. Paresis, by definition, is weakness, but the quality of this UMN paresis differs significantly from the quality of LMN paresis. Incomplete LMN disorders interfere with the ability of the patient to support weight but not with initiation of the gait. These patients hop fast their weight is held up and if they have enough LMN function to try to hop. UMN disorders result in a delay in protraction of the limb when trying to walk or hop or result in a complete absence of any protraction. Subacute or chronic lesions of the prosencephalon do not affect the gait, but postural reactions are delayed in the limbs that are contralateral to a unilateral lesion. This delay in postural reactions is caused by the interference with both the prosencephalic UMN pathways and the conscious pathway for GP. It is common to read descriptions that refer to this as a hemiparesis. This is incorrect because the GP system is also involved, and it is misleading because the gait is normal. In practice and in this text, we use the terms hemiparesis and ataxia only when the gait is abnormal and not when the only abnormality observed is a delay in the postural reactions. In peracute, being hit by a car or receiving a gunshot wound or following surgery or infarction, lesions of one frontoparietal area of the cerebral hemisphere, a mild to moderate visible contralateral hemiparesis and ataxia exist for up to 2 to 3 days following the injury. After that, the gait is normal on a level surface, but the postural reactions are delayed. These latter clinical signs should be described as normal gait with abnormal postural reactions. Spasticity. The UMN pathways contain axons that are responsible for both the activation and inhibition of LMNs that innervate extensor and flexor muscles via the central pattern generators. However, most lesions that affect the UMN result in a release of anti-gravity extensor muscles from inhibition, which supports the major role of the UMN in this inhibitory activity. The release of extensor motor neurons from inhibition results in hypertonia, or spasticity, of the extensor muscles. This may be observed in the stiff nature of the impaired gait and the increased resistance to passive manipulation of the limbs. Thus, the quality of UMN paresis is spastic paresis or paralysis. Recall that in LMN disorders, a flaccid paresis or paralysis exists. A classic example of what happens when the LMN never receives any UMN influence is described in Chapter 3 in the section on spinal cord malformations. See video 3-4, which shows a cemental calf that has no cranial-lumbar spinal cord. Note the extreme pelvic limb spasticity and the stereotypic spinal reflex walking movements. This certainly emphasizes the role of the UMN in the inhibition of anti-gravity extensor motor neurons. Hyperflexia. The same release from inhibition may be seen in the spinal reflexes, especially the patellar tendon reflex, in which it is more brisk than normal or occasionally is repetitive after a single stimulus, known as clonus. Flexor reflexes may be hyperactive or even repetitive following a single noxious stimulus. The crossed extensor reflex is another form of release from inhibition caused by UMN disorder. The crossed extensor reflex is normal in a standing animal and is used to support weight when the weight is taken off the opposite limb. It is abnormal when present in a recumbent animal but is easily confused with voluntary movement if the animal is able to struggle to move away from a noxious stimulus. It is best observed in a patient that has a serious enough UMN lesion to result in the absence of any voluntary movement. This abnormal reflex is seen when a mild noxious stimulus causes flexion of the limb stimulated and extension of the opposite limb or crossed extension. In our opinion, the presence of this reflex is just another clinical sign of UMN disinhibition and has no prognostic value. In severely disinhibited lumbosacral LMNs, a single noxious stimulus may induce what is referred to as a mass reflex. Following a single noxious stimulus to a digit, that limb or both pelvic limbs repeatedly flex 3 or 4 times, and the tail may flex without further stimuli. A single noxious stimulus to the tail may elicit repeated tail and pelvic limb flexion and even urination. With UMN lesions, the quality of the paresis varies with the severity of the lesion and the specific tracts involved in the lesion. In most situations, if no disturbance to the gray matter of the intumescences has occurred, the spinal cord lesion that affects the UMN results in normal to hyperactive spinal reflexes and normal to increased muscle tone in the limbs caudal to the lesion. Any atrophy that occurs in chronic lesions is caused only by disuse. Many case examples of patients with spinal cord disease are presented in Chapters 10 and 11. Release from inhibition. A fundamental principle of the development of neurons is their ability to generate and transmit electrochemical impulses to other neurons or to effector organs. This fundamental activity requires significant inhibition to result in smooth, regulated muscle action. A complete loss of this inhibition at the prosencephalic level results in a seizure, which is the ultimate example of uncontrolled uninhibited release of neuronal activity. Other examples of less fulminating uninhibited spontaneous neural discharge include decerebrate or decerebellar rigidity, tetanus, and tetany that represent uninhibited innervation of anti-gravity muscles and various forms of myoclonus and movement disorders. The extrapyramidal system plays a major role in most of these examples of spontaneous involuntary muscle contractions. Decerebrate and decerebellar rigidity. The classic example used by neurophysiologists to demonstrate the role of the extrapyramidal system in the control of motor tone is the phenomenon of decerebrate rigidity. When the brainstem is transected between the rostral and caudal colliculi of the midbrain, an uninhibited extensor tonus of the anti-gravity muscles is produced. The head and neck are markedly extended dorsally, which is known as opisthotonus, and all 4 limbs in the quadriped are rigidly extended. This is explained as a release mechanism. The myotatic reflexes involved involving the extensor muscle elements have been released from the effects of the descending inhibitory UMN pathways. The facilitatory centers in the pontomedullary reticular formation and the vestibular system can function autonomously, whereas the inhibitory centers in the pontomedullary reticular formation require continual input from the cerebral cortex, basal nuclei, and cerebellum to function. This experimental midbrain transection removes all of the prosencephalic input, causing the imbalance that is observed as a release phenomenon or decerebrate rigidity. The alpha and gamma elements that innervate extensor muscles have been released from the influence of the caudally projecting UMN spinal cord tracts. The vestibulospinal tracts also contribute their facilitatory influence to that of the radiculospinal tracts. A similar release phenomenon occurs after surgical ablation of portions of the cerebellum, especially those that include the rostral vermis and adjacent hemisphere. In this decerebellar rigidity, opisthotonous and extensor rigidity of the thoracic limbs are present, but the pelvic limbs are often held in extension or flexed at the hips. Figure 8-15. Brainstem lesions that cause decerebrate rigidity also usually involve the ascending reticular activating system and cause serious deficits in the patient's sensorium, including coma, whereas a patient with a rostral cerebellar vermal lesion that causes decerebellar rigidity has a normal sensorium. It is our experience. Most natural disorders that result in opisthotonous and extensor rigidity involve the cerebellum more than the brainstem, but many involve both areas. When presented with a patient that has opisthotonous and some degree of extensor rigidity, it can be reliably assumed that some portion of the lesion involves structures in the caudal cranial fossa, with the exception of a patient with tetanus, which is described later. Video 8-1 shows an 8-year-old male working mixed breed coonhound with a history of 3 to 4 weeks of progressive loss of his normal performance that began with difficulty in using the pelvic limbs and progressed to the thoracic limbs. At the time he was presented for examination, he was unable to get up. Notice severe disorientation and his tendency to assume a posture of opisthotonous associated with extensor rigidity of his limbs. Occasionally, the pelvic limbs are held in a flexed hip position. His spastic tetraparesis is worse on the left side. His abnormal nystagmus is caused by the involvement of the vestibular system in the lesion. The anatomic diagnosis was a disorder of the structures located in the caudal cranial fossa, the cerebellum, pons, and medulla. The major disorders to be considered in the differential diagnosis of this progressive syndrome include neoplasia and inflammation, granuloma to meningoencephalitis, viral, protozoal, and fungal infection, abscess. Radiography demonstrated an extraparenchymal mass lesion centered in the tentorium cerebelli. At autopsy this was diagnosed as an osteosarcoma that severely compressed the central region of the cerebellum and the underlying pons and medulla. See case example 22-3 for a complete description of this case and photos of the radiograph in the lesion. Figure 8-15 shows an 8-month-old brown Swiss heifer, which, in the course of 24 hours, became blind, pyretic, and ataxic, and by 36 hours had become recumbent and obtunded and assumed the posture of decerebellar rigidity seen here. The anatomic diagnosis is a diffuse brain disorder. This heifer has a diffuse metabolic encephalopathy caused by thiamine deficiency, in which the lesion is referred to as polioencephalomalacia. This posture is caused by the effects of the metabolic disorder on the anti-gravity inhibitory mechanisms in the cerebellum, pons, and medulla. Extrapyramidal nuclear lesions. Information about specific clinical signs that relate to diseases causing focal extrapyramidal nuclear lesions is limited. For example, for the often asked question what happens when the caudate nucleus or the substantia nigra is destroyed, we do not have a reliable answer other than that some disturbance of the motor systems may occur or no clinical signs may be present at all. We offer 4 motor type disturbances for consideration. 1. A compulsive activity. A common sign of prosencephalic disorders that are usually or predominantly unilateral is the behavioral disorder of compulsive pacing in a circle or standing with the head and neck turned to one side, pleurathotonous. As a rule, the patient circles with a normal gait towards the side of the prosencephalic lesion, but exceptions to this occur. The tendency to turn towards the side of the lesion is the basis for this being referred to as the adversive syndrome. The specific location of the lesion responsible for this compulsive activity is unknown. Most are in the frontal or parietal lobe of the rostral thalamus and often involve the basal nuclei. This compulsion may be the result of an interruption in the normal circuitry from the cerebral cortex to the basal nuclei and then to the thalamus and back to the cerebral cortex. As a rule, the patient is aware of its environment with no or little loss of its sensorium, but this depends on the extent of its disease process. Substantia nigra lesions are occasionally reported to produce this kind of compulsive activity, which may relate to their connections with the caudate nuclei. See figure 8-16 that shows an MR image of a 12-year-old male miniature pinscher who experienced a sudden onset of compulsive circling to the left of 2 days duration. The neurologic examination was normal. The MR image shows a localized hyperintensity in the left caudate and lentiform nuclei and adjacent internal capsule that was interpreted as an ischemic infarction. This area is in the distribution of the striate branches of the left middle cerebral artery. 1 month later, this dog was no longer propulsive to an abnormality in neck, head, and eye position. This abnormality has been observed in dogs with focal infarction of cerebral extrapyramidal nuclei, thalamic nuclei, and the subthalamus. These are usually contralateral to the side of the lesion and consist of abnormal head posture, head tilt or turn, neck posture, cervical dystonia resulting in torticollis or pleurathotonus, or both, which may be permanent, transient, or episodic. Abnormal nystagmus, strabismus, or both may also occur. 3. A movement disorder. Movement disorders are described in Chapter 20 in the discussion on uncontrolled involuntary muscle contractions. Their pathogenesis is poorly understood, but a disturbance in the motor circuitry as just described is often proposed as the origin of these movement disorders. 4. Nigropalidal encephalomalacia. This is a disorder observed only in horses when these two groups of extrapyramidal nuclei undergo necrosis. Horses that consume the plant called yellow star thistle, Centrae solstitialis or Russian knapweed, Centrae repens, for a period of a few weeks suddenly develop acute bilateral necrosis of the substantia nigra and globus pallidus. Figures 8, 17 and 8-18. Most of the clinical signs observed involve dysfunction in prehension and swallowing caused by spastic paresis of the temporomandibular joint, lips, and pharyngeal muscles. These horses become depressed and inactive and die of starvation. Occasionally, some mild propulsive activity of the head muscles may exist, but no gait propulsion or movement disorder is observed. A toxic compound has been identified in C. solstitialis that is similar to dopaminergic neurotoxins that have been studied in humans. This bilateral nuclear necrosis is readily diagnosed by magnetic resonance imaging, MRI,